So welcome to Hanover in the spring. It's going to snow today, and as the 3 months of mud season begin. So I want to hear, I'm Ed Marins, I'm the class of 13. I'm the CMO at Dartmouth-Hitchcock, and we have an impressive panel here with Jeff, Chris, and Leslie. We're all here because we got emails from Alice and Katie, which you can never say no to either one of them, but two of them kind of ganging up on you really makes it more of a pressing issue. So we're really happy to be here and talk a little bit about end-of-life care and the applications and really the translation of kind of our work through MHCDS to the work that we're involved in. I spend most of my time with project managers who hold me to meetings that have discrete time elements for everything, which I routinely violate, but we try to put together kind of an overview of what we want to be able to do in this talk, and let me just talk about that a little bit. I'm going to give a little bit of an overview of the state of end-of-life care in the US, a little bit through a number of lenses, and certainly the lens of TDI and MHCDS and some of the work that's been done at Dartmouth, but also nationally. We're going to have presentations by Jeff, Leslie, and Chris, really focused on their areas, but they're really not limited to those areas. They have expertise and involvement across the scope of either their organization, their hospital, or really state and even nationally. The next step is the opportunity to generate ideas and share insights, which in symposia speak is an exercise for you. This will not be a PowerPoint, 3-point paper, choose someone, present. What's been great about this symposium is not only, there are three things. One has been to hear some incredible talks about the work that people are doing, successes, failures. The second thing is just getting together and having the ability to kind of interact with people who may not have been in your cohort and learning what they're doing. But I think what we've all experienced is that the conversations that have happened at the table have been really good. And what we want to be able to do is think about the things we're going to talk about, have some generative discussion at the tables for 15 or 20 minutes, and then share one of those with the group, and use that as an opportunity to interact with the panel around what are your challenges, what have you done, how can this be spread, how do we sustain this kind of change, a lot of the themes. So we want to build on some of the themes that have been echoed here already over the past 3 days. And that'll evolve into the work with our panel. So I want to just talk a little bit about the state of end-of-life care in the United States. I'm a CMO in an organization that has thought a lot about end-of-life care. I'm involved in 3 or 4 different projects as it relates to end-of-life care, partially because of interest, but partially because there's a lot that we can do and a lot that we can do better. We're going to learn more about that. I mean, I'm involved in affiliating with a region-wide home hospice agency, building a hospice and palliative care center, and thinking about how we do advanced directives and respecting choices throughout the organization. And this really resonates with a lot of our work, and I think end-of-life care is one of those things that resonates in any area you work, whether you're an interventional cardiologist, you're a pediatrician, you're an oncologist, or just a family member, and I think that's part of it. So the one thing I did want to say at the outset is that a couple things. Thanks to the people organizing this conference. I think of no better way to honor Bonnie, and I want to thank Peter by getting together and having conversation about the things that matter with the people you care about, and that is really what this is about. We will have some opportunity for questions, clarifying questions after each of the speakers, but the formative kind of how do I really do these things will follow. Any questions so far? All right. I would ask that when you do ask the questions, you wait for the people to come around with the mic, because we are taping this. The other thing is that there hasn't been, I know food has been a challenge here. If you feel like you're hungry between now and lunch, raise your hand and someone will bring you a cookie. So let's build on a little bit about what TDI and what we've learned from Dartmouth. This is a report that Dave Goodman produced with the TDI team, including Elliot Fisher. So we know, and we've talked about this the past 3 days, at least 90 million Americans live with at least one chronic disease. 70% of Americans die from a chronic disease. Gil might say die with, and I think that's okay. But people die from chronic disease. And 90% of Medicare patients, their deaths are associated with one of these 9. And we've talked about some of these. You know, this is heart failure, lung disease, cancer, the broad spectrum of cancer, heart disease, renal disease, vascular disease, and so on. 32% of all Medicare spending is on these patients in the last 2 years of their life. And this spending is mostly physicians' fees and hospitalization. So what do patients really want? And part of this was kind of understanding the trends. So what do patients really want? Do they want do everything possible? I want more time at the hospital if I can, especially in the ICU. Do they want to be at home? What do we know? So the majority of patients want to die at home, and yet more than half, 55%, end up dying in the hospital. In the communities in which patients get end-of-life care that is really more intensive, what do they get? We know they get more specialists, they get hospitalized more, and they're more likely to die in the most critical setting, the ICU. So compared with lower intensity regions, higher intensity settings have worse access to the medical care. So you really can't get to the person you need to, but you do end up in the ICU. There's reduced overall survival, actually, and there's lower quality of life. So when we think about kind of the things we heard about last night, about how we think about health, how we think about quality of life, people are trying to tell us something, and we have data, and this is about how we listen and how we execute. This is an article by, well, Julie lives across the road from me where I live in Norwich, way out in the sticks. So this is a team from another article about changing the end-of-life Medicare beneficiaries by a whole team at TDI, including Dave Goodman, Nancy Morton, who's at Dartmouth, and a whole team here, Julie Bynum as well, looking at kind of the changes that have happened really over the past, over a decade. And there were some really interesting insights that highlight some of this thinking as well. One was that there was the increase in ICU said in the last month of life. Okay. There was an increase in healthcare transitions, means I moved from the SNF to one hospital to another hospital. And there was actually an increase. If you look at this, there was actually hospice use at time of death had actually gone up. But healthcare transitions in the last 3 days of life had actually gone up. So we're shifting people around. And as hospitals worry about their mortality rates, the incentive to get someone out while they're alive someplace else and check the box that this pneumonia didn't end in death is a late transition. And what we understand is that people are making the transition to hospice care way late. It's sort of like at 8.5 months pregnant, you realize someone's going to have a baby. And we often know this a lot earlier in the process. And not only do we not, you know, the people that really know are the families and the patients. The IOM report came out in 2014. I've just got a couple slides highlighting, you know, the IOM is really wanting us to influence practice. It's visionary in terms of kind of the scope, but doesn't really have an armamentarium of ways to say we need to do this, but really talked about this and really summarized a lot of the thoughts. And I'll ask the panelists to talk about this as well. This is something Jeff has actually spoken about. So, you know, we know that people nearing the end of life have multiple transitions, lots of fragmented care. We know none of this adds to the quality of care or reducing the cost. We know that palliative care is associated with a higher quality of life. And a lot of things that fit in the squishy area of medical care that sometimes we're not all that trained to deal with, the spirituality, the communication, and the whole team approach of all the other people that actually matter. We know that the specialists involved with people at the end of life, oncologists, cardiologists, and other specialists, are fairly slow and late in getting people to palliative care in that approach. And what we're beginning to learn in a number of areas is that people actually live longer getting palliative care than not getting palliative care. And what does that mean? And again, most of the people who indicate end-of-life preferences choose care that's focused on alleviating pain and suffering. And this has been shown in a number of studies. Our own anecdotal experience at Dartmouth, we've embedded palliative care in our ICU. So the palliative care team rounds in the medical ICU with the medical ICU team. Isn't consulted, it's just part of the team. We've taken a day off the length of stay in the ICU primarily because we're listening to what patients and families are saying about process, about what our wishes are, things like that. So the recommendations are several, and they really go back to the beginning. It's not about how do you refer, but how do we begin to talk about this process of care decisions and advocacy and advanced care planning. And we'll talk about that a little bit. Comprehensive care should be seamless, high quality, integrated. This is mom and apple pie, and we want this for everybody. But it's very important for this population. Clinicians need to initiate conversations about end-of-life care choices. We're not all that well trained to do that, and I think we all realize that, but how do we get people to have those conversations? How do we begin that? And I think there needs to be pressure on the government to be able to kind of support this. If we're going to support, you know, hemodialysis, we should really invest in the support around how we deal with the people that die from hemodialysis, because 25% of that cohort die every year. And how do we think about that? The IOM talks about access to skilled palliative care and hospice where they receive. Interdisciplinary team. And this is the true interdisciplinary team of the whole spectrum of chaplaincy and everybody. I mean, Dr. Joe last night talked about healthcare delivery that didn't actually involve a doctor, but maybe a lawyer and a student and someone else. Certainly, this kind of care can be delivered by a whole team, being supported by a doctor, but not led necessarily. Access team may be on site via virtual consultation, and this is a novel area that we're exploring on many levels, certainly at Dartmouth and beyond. And we want to hear a little bit more about how we're doing this. Certainly, if you can run an ICU through a teleconsultation, think what you can do for palliative care. And another thing under services is that the IOM called for a public reporting of aggregate quality and cost measures for all aspects of the healthcare system related to end-of-life care. How do we begin to do this? This is led by TDI, led by Dartmouth. How do we understand this? How do we understand this better? And finally, clinicians and payers. Clinicians, we need to figure out how we can communicate, how we can collaborate, how we can manage symptoms. One of the biggest aspects of palliative care, especially in the home setting, is managing symptoms. Symptoms are what bring people to the ED. Coming to the ED is your ticket to the hospital, which is your ticket to the ICU. Often if you can manage symptoms effectively, and we have an armamentarium of things, you can change that paradigm, and it's a big part of it. And they've reached out to the societies as well to begin this process that we think about how the societies can lead this in advanced care planning and actions that are measurable, actionable, and evidence-based. This resonates with a lot of what we studied in MHCDS. And should be tied at some level when you get down to this to reimbursement. So these are visionary statements, but I think they resonate with the data and a lot of our own practice, which we'll hear more. So we have three panelists. We have Jeff Alderman, who's a palliative care physician from the University of Oklahoma and directs the Sooner Health Access Network, which is a statewide endeavor. Leslie runs everything, but she's going to talk about the emergency department and her work at Long Island Jewish. And Chris is involved in critical care at North Shore Medical Center, but runs a full spectrum of work. And this is really to highlight the great work she's doing. She had the courage to talk about failure, and any of us could talk about failure, but Chris, we get the full spectrum of Chris's experience here. So without further ado, I'm going to turn it over to Jeff.
Oh, thank you, Ed. Can everyone hear me? I'm on. Thank you for those opening remarks. It's really wonderful to see people who hold leadership positions in medical centers embracing palliative care, talking about palliative care, promoting it. That's happening more and more throughout the country. But sadly, I was reading an article last year in the Wall Street Journal where there's someone in Ed's position, a CMO of a major hospital in Texas, who said, we don't do palliative care here, we help people live. And I was just shocked, but that's just an example of the barriers that we're facing as a specialty. So for those of you that know me from the class of 2013, you know I'm pretty passionate about this issue, and I'll try to speak to some of the major points about palliative care, where it is now, and maybe a little bit about the future. But just to kind of pick up on Ed's introduction, palliative care is a specialty of medicine, like cardiology, like GI. You can be board